Welcome to the AOA Future in Orthopedic Surgery podcast series. This AOA podcast series will focus on the future in orthopedic surgery and the impact on leaders in our profession. These podcasts will focus on the vast spectrum of change that will occur as the future reveals itself. We will consider changes as they occur in the domains of culture, employment, technology, scope of practice, compensation, and other areas. My name is Doug Lundy, host for this podcast series. Joining us today is Dr. Judy Baumhauer. Dr. Baumhauer serves as the Associate Chair of Academic Affairs and Profession in the Division of Foot and Ankle Surgery in the Department of Orthopaedics at the University of Rochester. In addition to providing clinical care, she holds a position as a medical director of the PROMIS for the University of Rochester Healthcare System and is a board of directors on the Accountable Health Partners, ACO, for the Rochester region. She received her bachelor's degree from Springfield College in Massachusetts, her master's of science in biology from Middlebury College, and her medical degree from the University of Vermont College of Medicine. She completed orthopedic residency at the Medical Center Hospital of Vermont and a fellowship in foot and ankle surgery at the Medical College of Wisconsin. While working as an attending at the University of Rochester, she obtained an MPH degree from the University of Rochester Department of Community and Preventative Medicine. She's the past president of the American Board of Orthopedic Surgery, the American Orthopedic Foot and Ankle Society, and the Eastern Orthopedic Association. She currently sits on the board of directors of the PROMIS Health Organization. And also, Dr. Baumhauer was a Lieutenant Colonel in the U.S. Army Reserve. So, Dr. Baumhauer, welcome to the podcast series, ma'am.
Thank you, Dr. Lundy. Really appreciate being asked.
Thank you, Judy. Great to see you again, and I look forward to talking with you about this. So, in full disclosure, I've got to know Judy through our time together on the American Board of Orthopedic Surgery, and my ABOS partner, Charlie Salzman, and Judy had a very special relationship. They'd known each other for quite a while. They're both foot and ankle surgeons, and they are both intensely interested in patient-reported outcomes. And so we would love to talk about today the future of patient-reported outcomes in orthopedic surgery and where you see things are going. So can you give us a quick overview of how did you ever get involved in patient-reported outcomes, and why are you so interested in this stuff?
I think patient-reported outcomes are really the center of how the patient is feeling and functioning, and I'm all about that. I think we all are as orthopedic surgeons. We really just want what is best for the patient, and yet we would go into a clinic visit or something after surgery or before surgery, and we would ask the patients, hey, how are you doing today? And they would say, I'm fine. Well, are you able to, get back to work? And they go, oh, no, I can't get back to work. And then you'd sort of go back and forth on these questions, trying to gauge where they were feeling and where they were functioning. And it seemed like there might have been a better mechanism for that. So recognizing the patient is the center of what we're trying to do, and recognizing that there's probably a more validated way of collecting questions, patient-reported outcome measures came into being that seemed to fill that gap.
So how do y'all use those at Rochester in terms of taking care of patients? How does that actually work?
So we began in 2015 really investigating if we could collect patient-reported outcomes at site of service where we were seeing the patients. And in that time, believe it or not, it wasn't really commonly done. You just collected it really for research. You did it when you were interested in studies, and then you didn't collect it for big gaps of time. And then at the end of the episode that you were interested in, you'd collect it again and then look at pre and post and decide whether or not the patient did well. And we thought maybe if we look at it in continuity between, initially we did it at every patient visit, and then we did it at the points of time where change was going to happen, or we could think that change might be happening. And that's kind of how we moved it along. We started in orthopedics, and at our institution at the University of Rochester, we had it humming, literally within 6 weeks. We had it humming off of a custom platform that super smart people picked, and we used the PROMIS instrument. And other departments said, hey, we want to collect that too. And so we started spreading it across the institution. So now we have a system-wide collection of patient-reported outcomes measures that include PROMIS and a number of other instruments that the providers felt were important to assess on their patients to guide their treatment plans.
So let's suppose I'm a patient with a chronic foot problem that you've operated. How would you use that in my clinical care if I was coming to see you at the University of Rochester?
So I would use it to determine whether or not, first of all, originally the patient really collected it at when they checked in. They check in and they complete a assessment, and that assessment included physical function and pain and depression, because we felt that it was important to know how the patient was feeling and functioning. And it would pop up instantaneously in our electronic record on a graphic display. And because it was really easy to interpret on this graphic display, we could tell whether or not the person was improving, flatlined, or actually digressing. And based on that and what our prior treatments were, we could make some decisions of whether or not things were working or they weren't working. And it doesn't stop us really, Doug, from talking to the patient, hearing how they think they're doing. It's more of a kind of a validation of that we've understood their history correctly and that we can move along with whatever treatment plan might be the next one and share that with them.
So I'm sure that you looked at a number of the patient report outcomes. Why did you pick PROMIS as your standard for everybody?
Oh, prior to, it wasn't like PROMIS was the only thing that we collected prior to 2015. It was the wild, wild west. I mean, everyone collected their own stuff. Matter of fact, we had a really great spine surgeon that was with us at a point in time, and he used a QR reader code to scan the results in and be able to interpret the results. So he was like almost a little bit of a training vehicle for us, since we used QR reader codes to distribute the patient-reported outcomes to our patients, pull up the right ones. So we decided on PROMIS because it was a $100 million effort by the NIH to collect a centralized, validated, psychometrically sound instrument that looked at symptoms. So it was really about symptoms. So we'll probably get to this, but what we're in the midst of now with the knees and hips guys are they're collecting their Hus and Kus Jr. and they're going through all this trouble to collect it all. And now if the back guys come into play, are they going to collect oswestry? So now we have another instrument and another instrument and another instrument. PROMIS actually could transcend all of those symptom complexes and be a general health status measure that will allow us to only have to use one instrument and save costs and implementation issues.
Yeah, I think aren't the joint surgeons mostly using the Hus and the Kus because the federal government's requiring them to do this through the HARR for certain payments, right?
Oh, yeah. Well, it's Hus and Kus Jr. So,
Right.
and you say, well, what does that matter? Just a shortened form. No, it's not. What it is a combined function and pain score. So you can't really tease out whether or not the patient's functionally doing better or their pain's getting a little bit better, but they're not functioning any better, or that their pain is significant, but they're functional. It's combined. It makes it really troublesome. So from a standpoint of PROMIS, we have crosswalked the greater we, okay, not the little orthopedic surgeon me, we, the smarter guys than me,
Right.
have crosswalked PROMIS, physical function and pain, with Hus and Kus, which is the adult version rather than the junior. And that demonstrated that PROMIS is actually a better instrument than Hus and Kus.
That's crazy. I know that we had a talk today in Grand Rounds, and they were talking about the timed up and go test and other tests like that as well.
Yeah.
Y'all use stuff like that, and how do you feel that that responds or correlates with PROMIS or other patient reported outcome measures?
So I think there are a lot of different tests that you can use to try and delineate your patient's symptoms or activities and things. What I could see PROMIS being a jewel for is it would allow you to assess how a patient's feeling and functioning through an episode of care. And say you had specific areas that you were interested in delving down. So you want to know if the person was at risk to fall. So you might use a timed up and go test to assess whether or not they need some additional training around falls risk. I would tell you though, PROMIS physical function is a pretty good indicator of whether or not a patient has risk to fall. So there are always the way to drill down, and some of these other patient-reported outcomes measures will help you drill down, but perhaps you need to identify if you need to drill down, and that's where PROMIS is going to shine. It's going to be an indicator of whether or not patients doing well through their episode of care, or if things are going astray, then you can pull them out and perhaps drill down with something different that might influence how you might treat that person. I mean, PROMIS can't diagnose infection, right? It can
Right.
just tell you they're not functioning as well and they're having more pain. So you're going to need additional testing to determine why it is they're not feeling well or having more pain or not functioning as well. And I only use those two examples because we're orthopedic surgeons. But I got to tell you, my pulmonary guys are using shortness of breath. My GI guys are using GI distress. The urology guys are using social limitations because of urinary incontinence. People have social isolation. So there are actually over 300 symptom complexes with PROMIS that can be assessed.
So speaking of which, the psychometric ones seem to have a tremendous correlation with the physical PROMIS scores. I think y'all have identified a significant correlation there. Can you enlighten us some of that information?
You might have to clarify that a
Like
little.
the depression in the season and things like that, how that seems to almost parallel the physical function one. Am I right? Or
I'm not sure that's always right. I'll give you a great example. I would say someone who is depressed may not function as well. So that's where your correlation comes into play. But there are other things. I'll be in clinic and I'll look at their values and I'll see that they're functioning really well, but they're really depressed. And it's a change from where I saw them before. And I'll just say to them, like I said, it doesn't explain away. It's just a number. You need to have a conversation. So I'll say, hey, I noticed that you're kind of sad. And they'd say, oh, my dad just died. Well, that relationship is now tighter, my relationship with that patient, because I asked them about how they're feeling. And I
right.
noticed that they're feeling differently. A lot of times you might see them looking sad, but people are great at hiding stuff. So it's a great tool. I want to tell you one other thing. Sometimes there's depression from an episode. So we did a study on ankle fractures. So they had trimal ankle fractures and we fixed them and we got their PROMIS scores. We got pain interference, depression, and physical function. And even though their physical function was improving and their pain was getting less, we noticed also their depression was getting less. And we realized that really it was the episode of injury that made them sad. So as soon as they started to improve, their depression started to improve. In the beginning, I would look at this and I'd say, oh, it's a baseline score. The person's depressed and they have these injuries because trauma happens, right?
Right.
And I'd say, well, I wonder if I'm supposed to engage them with a counselor or something. But really, it's that they broke their ankle that they're sad. And you need to give them a little time to go through that. We saw the same thing with ACL reconstructions. Patients were depressed because they had an injury. And it doesn't always require an antidepressant med or a counseling event. Sometimes you just need to follow the patient along to see how those trends are happening. And that's, I think, really important too. And that's why collecting patient-reported outcome measures through the episode of care is important.
So y'all are collecting these on everybody that comes to the clinic, or
Yes.
wow. Tell me what kind of are you getting much pushback, or are people saying, why am I doing this? Or
I I wouldn't say that people are saying, why am I doing this? Sometimes they aren't as engaged with it as me. And so they won't actually explain it to the patients what's going on. So it becomes like another point where they get their blood pressure and they never talk about it. And sometimes the patients say, why are you getting my blood pressure? You never even tell me what it is. Same thing with patient reported outcomes measures.
Right.
So it's important to let the patients know how you're using that data or how it's guided you. And I have this whole spiel for patients. I say, although you're an excellent communicator, sometimes I have trouble understanding what people are trying to tell me. So I use this as a standardized tool to allow me to gauge really how you're feeling and functioning. And they appreciate that. So I go with it.
That sounds very well crafted.
I also want to tell you, Doug, it only takes less than a minute per symptom. We call them domains. So per domain, so if I do physical function, pain, and depression, then it takes actually 2.3 minutes. So patients don't have a problem with the time that it takes because we use a computer adaptive technology and item response theory. So you only ask the most appropriate questions. You don't ask them questions that go back and forth. It's not a static measure.
You're doing this on iPads or some form of.
And now we do it in Epic. Now we roll out through. So at the beginning in 2015, when we had our own custom platform, we did that probably until just a couple of years ago. So maybe 2023 or 2024, we swapped into Epic when Epic caught up. Before that, Epic didn't have the capacity and we didn't want to lose that.
All right. So put your magician's hat on. Where do you see these going in the future? Are they going to become more adapted? Are we going to start using them more? Will patients buy into it more? Will it affect payment? Just, I know that nobody can guess this, but you're as deep in the weeds in this as anybody I know. What do you think? Where do you think this would go in 10 plus years?
Our major change has been that CMS has now dictated that Coos and Coos Jr. will be collected or there'll be penalties. And it's going to be publicly reported, not directly, but through a kind of a calculation that they'll demonstrate. They'll say, of the patients that were collected, of the 60% of the patients that were collected here, the knees and hip replacement patients were able to get back to a certain level of functioning. And that's going to drive us. And it's coming. Anyone who hides is in trouble. It's already with hips and knees. Spine is already in play. They're in this process that's called teams, where the first 30 days are a bundled payment plan, and then there's risk. So it is coming down the line. They have shoulders, they have ankle replacements. It's hard to believe that ankle will be on the early phase of this, but it is. So they're going for the replacements and the high cost items first, and then they'll start to roll in other things. Of course, they have other areas of medicine that also are at risk. So things that are outside of orthopedics. So our friends and partners are facing this as well.
So if you were advising RFK Jr., the Secretary of Health and Human Services, on the way that patient report outcomes should be used, and you could just pick orthopedic surgery, you could pick medicine as a whole, how would you counsel him or whoever is Secretary of HHS that in the best practice you believe that patient report outcomes should be used, and what manner in the future to do what? How would you see that would benefit the healthcare of the country the most?
Yeah, well, I feel that patient reported outcomes, or giving the voice of I always call it the vote, right? Rochester was the vote for women. We initiated the vote for women. I always think the vote of the outcome of this is really with the patient. And patient reported outcomes measures a lot, gives the vote back. I want to tell you, though, if I were really advising someone, I would say that CMS picked the wrong instrument. They really should pick PROMIS, although they have PROMIS Global as one of the requirements. That's a static short form. It doesn't help you as much as if we had used PROMIS, the CAT tool, and it would save healthcare systems a lot of money. They wouldn't have to adjust for every single one. People don't understand how to score all these different ones. They The languaging for it is difficult. The communication is difficult. Patients don't understand it. It would be better to do some standardized work on that. And like I mentioned, PROMIS is crosswalked with a number of legacy instruments. So if you had a favorite legacy instrument like Oswestry for the spine guys or whatever it may be, more than likely PROMIS is crosswalk that, and there's a crosswalk table. And therefore, if you collected Oswestry because you love that at your institution, then you can crosswalk it and report the PROMIS. So I don't see that there's any downside in that. And I really think CMS should think about that.
The federal government even owns PROMIS, right? Well, they developed it, right?
Yep. Yeah.
So in the future, you see a much larger adaptation of these scores and the use within clinical care patients?
Absolutely. I just wrote an article for JBJS in the perspectives because one of the things that people are struggling with, and this is getting a little bit into the weeds, but it's around comorbidities and all the other things that affect patient-reported outcomes. And how can you know that this one value that you're providing is valuable? Somebody who has really bad diabetes and other cardiovascular, and their initial score is very low because they have a knee arthritis, and you score them and they fit into the realm of their preoperative score being eligible for knee replacement. And as a surgeon, you feel they're eligible. Even though they're impaired, they don't have much room for improvement because their other comorbidities are limiting their function. And then the reverse is true too, where somebody's functioning pretty darn well, but they fall outside of the score that CMS may feel is adequate for a baseline score, or that they are functioning pretty well and they're almost have a ceiling effect where they do get some improvement and they're happy they had it done, but they don't meet the threshold for CMS. So surgeons are getting penalized. Really, it's the hospital system that's getting penalized. So that, I think, is a major issue that people are wrestling with right now.
So you see further development in the scores to try to figure out how to work around that or identify that variable?
I think that people are trying to figure out where the sweet spot is. And we always say, we're orthopedic surgeons, give us the rules and we'll win the game. But I would tell you that it really is about the patient. We should always recognize that the patient should be the front and center here. And if they're having a significant amount of discomfort, pain-wise or something, and yet their function doesn't improve very much, but their pain does, they may not meet that threshold because Huss Jr. is a collapsed for both. So we can't really tease out the pain and the function. We could just get a total score. So anyway, there's a lot of details in how CMS is running this that are potential holes. And unfortunately, people will throw the baby out with the bathwater. They'll say, oh, see this is so wrong. And therefore we should never collect PROMs again. But that isn't what is right. We just didn't choose the right instrument. We chose poorly instead of choosing wisely.
All right. So as you know, AOA is all about development of leadership. And I have introduced these my current institution. We were not doing them well, and I kind of started that up. And then I also introduced them in the large practice I was in before I came up here. So how did you give us some of the leadership experience, leadership pearls that you deployed to make this a thing that your partners and that the folks at Rochester were bought in and then doing this? You said it clicked on very quickly and people jumped into it, but it's something new and people generally need leadership for that. How did you lead that effort? What leadership was done in that? How did that whole thing turn about? Can you give us examples so folks trying to undertake this can maybe learn from those examples as they try to influence the adaptation of PROMs into their practice?
Sure. Well, first of all, I would totally allow any person that's interested in patient-reported outcomes to contact me. We published on how we implemented this and things like that. Number one is nothing is free. I realize that. and you have to have some buy-in from the institution. Now, because it's now tied to reimbursement to some extent, and it's expanding, that's going to be a little easier because the CMS is going to do that job for you. But I would tell you that you still need the first string guys and gals to help you out and make sure that there's some support through IT and your Epic training team and things like that if it's going through Epic. You can't reinvent the wheel. You have to make it fit into a system that's already been working for you. There are ways to do that. There are also a lot of people that are already collecting this. Don't feel like you're the first one. Don't reinvent the wheel. There's also Epic teams that have done this. For PROMIS anyway, there is a website, healthmeasures.net, that can help you implement PROMIS or talk to you at all about other patient-reported outcomes that you might be interested in.
Wow, this has been extremely helpful. So it has been an absolute pleasure talking with my friend, Dr. Judy Baumhauer, about the future of patient-reported outcomes in orthopedic surgery. So, Judy, thank you so much for being on the podcast, ma'am.
Yeah, thank you, Doug. Thank you for your patient-centered approach. I know that you believe, just like me, that the patient's number one in the equation here. So really important. Thank you.
Yes, ma'am. Thank you. And y'all stay tuned for future episodes in this podcast channel series.